The last operation I'm going to talk about is the duodenal switch, or biliopancreatic diversion duodenal switch. It's a little complicated in terms of looking at the slide here, but you can see that the duodenal switch operation does have a sleeve gastrectomy as part of it, so removal of the stomach, and then there's a bypass that goes to just below the pyloric valve on the stomach here in the duodenum, and it's a very short bypass, so that this really is a pretty highly malabsorptive operation, because only this little segment of small bowel does most of the absorption. Food going through this part of the small bowel does not have a lot of digestive enzymes, and food going through the colon, there are calories in the colon, there are nutrients in the colon, and Dr. Scopanero showed us that colon will absorb some nutrients, but not much. So in terms of actually putting calories into the toilet, this does. It is the absolute strongest tool for weight loss. It is the absolute strongest tool for diabetes. It truly is malabsorptive. When I say it's growing in popularity, it's not taking off in popularity, but it does have its place, and I think we'll see more surgeons offering it, like myself, where I did not offer it in Duluth, and we do plan on offering it here in Northwest Washington. But I still think we'll be very cautious in terms of how we help patients select this procedure. Many people come in reading things or hearing things on the internet that this is the easiest operation in terms of weight loss, or that you can still eat and enjoy food. And I think some of that is a misconception, that with the sleeve and the bypass that you can't eat and enjoy food. It's really not the case. With the sleeve and the bypass you still can eat and enjoy food as well, but certainly you can overeat more with the switch and still lose weight. But most people don't want to actually overeat. They just want to feel full. They want to have food. They want to not be on a diet. And you do not have to be on a diet with any of these operations in the same way as you are in terms of that being deprived or being hungry all the time. Now, the duodenal switch operation really does have the highest mortality rate, the highest complication rate in terms of major complication of any of the procedures. It has been done mostly in the very sickest people, and so that may be a source of some of that, but it is a bigger operation. It also has the highest rate of malnutrition, because you are pushed right to that level of malabsorbing things, and so osteoporosis, anemia can be worse with the switch than with any other procedure. It also has some side effects in terms of liquid stools, or really terrible odor, both body odor and with flatus, with farting, what Dr. Scopanero in Italy calls putrefaction. It really is different from the normal smell. It's almost sometimes like, by reports, like a rotting flesh kind of smell when you pass gas. And that can be, for some people, a terrible thing. I don't have a lot of long-term follow-up with patients on this, and so I can't tell you anything primarily from me sitting with patients talking about this. Much of my knowledge of this comes from the literature and from conferences. But I think sometimes things get overplayed both for and against. I do know several surgeons that do duodenal switch operations fairly regularly, and they say that many of these things can be managed with a patient who's willing to make some changes. But that's not a fix it and forget it operation for sure. You absolutely have to have very close long-term follow-up with this operation. This is just a little summary slide showing the four main operations, leaving the plication out. And you can see here that the biliopancreatic diversion duodenal switch is only about 5% of operations in the U.S. The lap band has been up to 40%. That number is falling. I say lap band, pardon me, the adjustable gastric band. There are two different brands of band, the realized band and the lap band, which is made by Allergan. They're both good bands. They both have potentially some advantages and disadvantages over each other. It's very hard to tell if there's a major difference. Like I said, that number is falling. The main reason that the sleeve gastrectomy, and it's probably more like 10% now than the 5% when this research was done, that number may even be higher than that. The main reason it's not completely taking over is because of insurance coverage and Medicare coverage. I think that the sleeve, when I said it was favored by many surgeons, I think the sleeve I would not be surprised with equal coverage for all of these procedures to see it be more than 50% or close to 50% of the work that we do. Now, revisional operations, I just want to touch on here. This is a very specialized issue. It's very individual. Older procedures that have been done 20 and 30 years ago, sometimes the non-divided staple lines or suture lines that we use could break down. Sometimes we can go reestablish that. We certainly can remove lap bands and convert to other procedures, or convert sometimes bypasses to sleeves or sleeves to bypasses. Again, I don't want to get overly technical in this talk. Just be aware that those are issues that can be offered. Certainly we do go back and reoperate occasionally in people for gallbladder problems, or sometimes for abdominal pain if they have ulcers, or to explore for scar tissue, just like we do with any operation that can cause a bowel obstruction, things like that. There may be future procedures that we do through the mouth to retighten things that have loosened up a bit. So this is a whole family of procedures that is probably worth its own hour-long talk. On the horizon, at this point in the main part of my talk just now, that is what's on the near future horizon. Vagal stimulation, or stimulation of the nerve that's called the vagus, V-A-G-U-S nerve, has been tried for over a decade. Many different studies have been done. There does not seem to be anything there that's going to be long-term for most people. This natural orifice surgery or endoluminal surgery, going just through the mouth with no incisions, is certainly something that's promising for research in the long term, but there's a lot more hype than safety at this point. I do think that the people who are doing work on it are to be commended, and eventually we will have some better tools, but we are probably a lot further off than even the next 3, 4, 5 years for most people. Single port surgery is something that I've done and done courses on. It is only a cosmetic benefit at this point, just one incision, one small incision, rather than multiple very small incisions. There's some real limitations to this. I'm happy to talk to you about it. I'll be happy to do some single port work, but I don't want people to think that this is a radical improvement over what we already do.